Good evening, ladies and gentlemen. Welcome to join this healthcare webinar meeting. And this evening, we will talk about the application of transient elastography in the diagnosis of liver disease and its complications. And it's a great honor to invite two great professors to join this meeting and as the speaker. And the first speaker is Professor Zaigham Abbas, and he is the professor and head of the Department of Gastroenterology of Dr. Zaigham University Hospital. He is also the president of the Pakistan Society for the Study of Liver Disease Governor. And tonight, he will give us the topic about the evaluation of the transient elastography on esophageal and gastric bleeding risk. Thank you very much to share your topic, Dr. Zaigham Abbas.
Thank you very much, Professor Yang Ling, for your kind introduction. So I'll share my screen now. So topic that I will be discussing is the evaluation of transient elastography in predicting esophageal and gastric varices presence and its bleeding. So portal hypertension dwells when there is resistance to the portal flow, and the resistance may be in the liver, and which occurs in the cirrhosis of liver, or resistance may be prehepatic like portal vein thrombosis, or post-hepatic like Budd-Chiari syndrome. So what are the consequences of portal hypertension? There are several consequences that may happen, like variceal hemorrhage, portal hypertensive gastropathy, ascites, spontaneous bacterial peritonitis, hepatorenal syndrome, hepatic hydrothorax, hepatopulmonary hypertension, portopulmonary hypertension, and cirrhotic cardiomyopathy and portocholangiopathy. So these are several complications that once portal hypertension is developed, these may happen. So I will be focusing today now on varices. As you know, varices may be present in the esophagus, the varices may be present in the stomach, like we have the fundal varices, then ectopic varices may appear in duodenum, in rectum, and in the small intestine as well. So approximately 50% of all patients with new diagnosis of cirrhosis have a gastroesophageal varices. Prevalence of varices increases with the severity of illness. Like if the person is a child to class A, then the probability is 42%. In child class B, we have the 71% probability, and child class C, we have the 75% probability. So as the portal hypertension becomes more severe, the probability of varices becomes more pertinent. In patients with compensated cirrhosis, varices develop at a rate of 7 to 8% per year. Small varices progress to large varices at a rate of 10 to 12% per year. And we know that the variceal size is the main predictor of the bleeding from the varices. Greater the diameter, greater is the risk of bleeding from the varices. So annual risk of variceal bleeding from small to large varices 5 to 15%. So larger the varices, greater the annual risk that these varices may burst and start bleeding. We have the very high mortality associated with variceal bleeding, which is about 20% mortality within the 6 weeks of variceal bleeding. And if there is rebleeding, then the risk becomes more and the mortality increases. This may become 33%. And the risk of rebleeding without any endoscopic intervention is about 60%. So how can we predict the formation of varices? This depends on the portal hypertension, and measurement of the portal hypertension is by hepatic venous pressure gradient. So here you can see a balloon in the hepatic vein, and when this balloon is not inflated, it measures the free hepatic pressure. But when you wedge it, inflate it, it measures the wedged hepatic pressure. And the difference between the free hepatic pressure and the wedged hepatic pressure is the hepatic venous pressure gradient. And hepatic venous pressure gradient is the pressure gradient between the inferior vena cava and the portal vein. So if the hepatic venous pressure gradient is more than 5, then these patients have the portal hypertension. Normally this is 5 or less. Clinical significant portal hypertension, we say when this is more than 10 millimeter of mercury, when the varices start developing and patient may decompensate. At 12 millimeter of mercury hepatic venous pressure gradient, then varices, hemorrhage, and ascites may occur, and the risk become more after the 16 millimeter of mercury. Then if the patient's hepatic venous pressure gradient is more than 20, then there is a high risk that will not be able to control the variceal hemorrhage, and this is more associated with mortality. So how can we predict hepatic venous pressure gradient? One thing that one way I mentioned was the putting the balloon in the hepatic vein and directly measure. But there are indirect ways to measure these pressures, and we'll discuss that, because hepatic venous pressure gradient depends on the degree of liver fibrosis, and there are ways to measure the fibrosis in the liver. Fibrosis may be measured by the elastography that we'll be discussing now in detail. Elastography may be transient elastography, 2D shear wave elastography, or magnetic resonance elastography. There are also some biomarkers like FIB4 and fibrotest. And one direct way is that we can do the liver biopsy and see the degree of fibrosis and document cirrhosis of liver, but that would be the invasive method. So how we measure the transient elastography? We use an ultrasound transducer probe, and we generate vibrations of mild amplitude and low frequency, which is about 50 megahertz, 50 hertz. These are transmitted to the liver tissue. This results in an elastic shear wave that propagates through the liver, and then the probe utilizes the pulse echo ultrasound to follow the propagation of shear wave and to measure the velocity. The velocity of the wave is directly related to the tissue stiffness, which correlates with the fibrosis. So we take measurements in the right lobe of the liver, where the lower intercostal space, which may be 9-10 intercostal space, and A mode image is displayed to assist the operator in selecting the measurement zone. And then in the bottom on the right side, we see the values of measurements, and we see the 10 measurements and their mean value. And we see the interquartile ratio, which should be ideal. We should be ideally less than 25% if we have the correct reading. And the results are expressed in kilopascal and can range from 2.5 to 75. Then another property of this instrument is that we have ultrasound attenuation parameter, which depicts steatosis. But we'll be concentrating more on the elastography aspect. So here, when we apply the probe, then it generates a sort of cylinder, and the measurement of cylinder are about 4 centimeter, and the width of the cylinder is about 1 centimeter. So this is the area which is in the liver, and the average of this area we measure the elasticity. And mind it that this is 100 times bigger than the biopsy sample. So we are able to see a large chunk of liver tissue and measure our elasticity. So these are different values. As I mentioned, that values are, there is a wide range from 2.5 kilopascal to 75 kilopascal. But if elasticity is less than 7 kilopascal, then the chances of fibrosis are very small. There is no fibrosis or very mild fibrosis. But if this is more than 7, then this means that the patient is developing significant fibrosis. And if the kilopascal value is more than 12.5, then it means that this patient may be having cirrhosis of liver. So this is the different ways, box plots of the liver stiffness values for each fibrosis stage. As we can see, these are the two different studies that have compared these values. And if there is no fibrosis or mild fibrosis, you can easily predict. If there is cirrhosis, you can easily predict from, but there may be overlap between F2 and F3 fibrosis. So these are two different studies that have addressed this issue. So there are some limitations of this fibroscan, that there is lack of anatomic orientation, limited depth of penetration is there. Specific requirements for the patient's positioning are there. Then fluid and adipose attenuation. This fluid and adipose tissue attenuate the shear wave propagation, which means that if there is ascites and if there is adiposity, much adiposity, then there may be a problem in getting the correct values. And this may also happen if the patient is in congestive heart failure, when there is elevated central venous pressure. So cutoff values for diagnosing significant fibrosis, F2 more than F2 or cirrhosis vary depending on the underlying tissue. But here we can see and say that if this is more than 7 kilopascal, then it shows that the patient is developing significant fibrosis. And if this is more than 11 to 14, depending on the etiology, then we may say that this patient has got the cirrhosis of liver. So people have tried to find out and drawn area under the curve. So AUCs were drawn and cutoff various ROC curves were made. And you can see that if we take the 13.6 kilopascal, then area under the curve is 0.7, which is good, fair enough to predict cirrhosis of liver. But if this is 35 kilopascal, then this area under the curve is 0.99. It means that we are very much sure, 99% sure, that this patient is having cirrhosis of liver. So value greater than 13.6 can be used to predict that this patient is having significant cirrhosis and portal hypertension. And value greater than 21.5, we can say that this is a patient who is having significant portal hypertension. Between 13.6 and 21.5 kilopascal, indeterminate values are there. Patient may be having cirrhosis, but may not be having significant portal hypertension. So here there are of my patient. Here you can see the patient who has the no fibrosis, a very mild fibrosis, and we did the fibroscan. This was 6.1 kilopascal, and there was hardly any fibrosis. There were no varices. So if you can see here that the x-axis is showing the milliseconds, the speed. It is taken longer for the shear wave to pass through. But if there is fibrosis or cirrhosis, then you can see the slant is different from this slant, and this less time, the velocity is higher if the patients have cirrhosis, and the kilopascal values become higher. So this is a study of 1,000 patients with cirrhosis, And this study shows that if there is grade 2 to 3 varices, then the value of elasticity would be much higher as compared to the smaller varices that are grade 1 varices. So 45 kilopascal was the average for grade 2 to 3, grade 2 to 3 varices, and for the smaller varices, this was 26 kilopascal. So we can predict from the fibroscan that if the patient has developed varices or not, like if the patient's stiffness is more than 21, this patient may be having varices, and if this is up to 26, the varices size may be small, but if the varices have become large size, this would be related to the higher kilopascal value on transient elastography. And just on transient elastography, we may say that this patient may be harboring large varices and we should do something, otherwise this patient may bleed. Like if the kilopascal value is more than 50, then there is a high risk that the patient will start bleeding spontaneously. We do need some sort of intervention to stop the varices, like varices bleeding, like band ligation. So this is another study which is again showing that if you have got the grade 2 to 3 varices, then cutoff should be more than 27 to predict presence of large varices, and this has got the 88% sensitivity and high negative predictive value, which means that if the value is less than that, there is less chance of having large grade 2 to 3 varices. If there is past history of variceal bleeding, again we can say that if the cut here this study is showing 62 kilopascal cutoff, then if this is achieved, then this is very much specific, 93% that this patient might have bled in the past or will bleed soon. So Bavino 6 addressed this issue, and they came across certain recommendations, and their recommendations were that if the transient elastography value is less than 10 kilopascal in the absence of other clinical signs, then this ruled out compensated advanced chronic liver disease. So value less than 10, it means that patient is not having any advanced compensated chronic liver disease, and value between 10 and 15 are suggestive of that, and value more than 15 are highly suggestive that this patient would be having compensated advanced chronic liver disease. So clinically significant portal hypertension, according to the Bavino 6, in the patients who have clinically significant portal hypertension, if the liver stiffness is more than 20 to 25, this may be alone, but according to some studies, they have also combined platelets and spleen size. Then this patient is having clinically significant portal hypertension. So this patient would be having varices, and greater the transient elastography, greater is the chance of higher, greater diameter of varices. Regarding to Bavino 6, patients who have the stiffness less than 20 kilopascal and platelet count more than 150,000 have a very low risk of having varices requiring treatment. They may not be having varices or small varices, so we can avoid screening endoscopy in these patients, but these patients can be followed yearly for the repetition of transient elastography and platelet count. If liver stiffness increases or platelet counts declines, these patients should undergo screening endoscopy and to do the needful treatment in these patients. Then they were expanded Bavino 6 criteria, and they came across with some lower values for platelet count. This study shows that even if the platelet count is more than 110, according to Bavino 6, this was 150. Even the platelet count is more than 110 and liver stiffness may be less than 25 kilopascal, then these patients are less likely to have large varices. So by these guidelines, we can avoid 40% of the endoscopies and miss less than 5% of the large varices that require treatment. And this is the study which is comparing the Baveno 6 and expanded Baveno 6 criteria. As you can see in both of these criteria, there is a very small chance that we'll be missing large varices if we follow this criteria. This would be 2.3% in Baveno 6 and 2.6% in the expanded Baveno 6 criterion. So with these criteria, if the platelets are more than 110,000 and transient elastography is less than 25 kilopascal, we can postpone the screening and these patients should be kept under observation. And if the platelets start declining further or the transient elastography starts increasing further, then these patients should undergo screening. This is an interesting study that has recently appeared. So this was the retrospective analysis, and these are the patients where the baseline liver stiffness was available more than 10 kilopascal. They only included with patients with advanced fibrosis, and they followed up the patients longitudinally. So what the criteria was, if there is within the follow-up period, they kept on doing the transient elastography. If there is improvement, which is reduction of more than 20% of the stiffness, then this is improvement. Stable disease means reduction of 20% or an increase of 20%, and impairment means an increase of 20% or more. So if there is stiffness increase more than 20%, it means that there is further impairment of the elasticity of these patients. So these patients are monitored with liver decompensations, which included variceal bleeding, liver cancer overall, and liver-related mortality. Mean follow of the patients was 35 months of these patients. And we can see one parameter was the baseline liver stiffness measurement, and this was independently associated with hepatic decompensation, liver cancer, overall mortality, and liver-related mortality. And then they further did the analysis with the liver stiffness measurement during the follow-up period. And for this 533 patients, data was available. And according to the criteria that were laid down, the follow-up changes in the liver stiffness, like if there was more than 20% increase in the liver stiffness, which is the further impairment of liver stiffness that was associated with hepatic decompensation, liver cancer, overall mortality, and liver-related mortality. So baseline liver stiffness is important. As we can see, this can predict who are the patients who are going to decompensate or have the variceal bleeding. And in this study, there was the cutoff was 21 kilopascal, and then they follow up the patients with time, and they showed that if there is further impairment of the elasticity, there is more chance of having decompensation. And number of the events in this bar chart, we can see number of the events increase if there is further impairment of the elasticity. So this is the summary of this study, which is the delta change in the liver stiffness measurement less than 20%, which means the patient is improving, less risk of complications, stable disease, there is a moderate risk of complications, or advanced disease, which means increase in the elasticity more than 20% when the risk of decompensation, SCC, and liver-related death and overall death increase. If the baseline liver stiffness measurement is more than 21 kilopascal, there is a high risk of liver decompensation even at the baseline. Is there any value of control attenuation parameter or ultrasound attenuation parameter? This is one study that favors that controlled attenuation parameter, ultrasound attenuation parameter, which is more than 220 decibel bar meter. This is associated with increased risk of decompensation. and the bacterial infection in patients with compensated advanced chronic liver disease. But another study that has addressed the same issue shows that the control attenuation parameter, ultrasound attenuation parameter, does not predict hepatic decompensation in patients with advanced chronic liver disease. So in conclusion, patient with liver stiffness less than 25 kilopascal and platelet count more than 110,000 have a very low risk of having variceal bleeding and having clinically significant portal hypertension, and we can avoid screening endoscopy in these patients. If the patient's liver stiffness measurement is more than 50 kilopascal, these patients are at a very, very high risk of having history of bleeding varices or may bleed in very near future. In patients with compensated advanced chronic liver disease, baseline liver stiffness measurement is important, and also we should follow up these patients with transient elastography to see any further deterioration in the liver stiffness so that we can predict any risk of variceal bleeding in future or decompensation in future and mortality. Thank you very much.
My task is today, what's the role of transient elastography in the assessment of the liver disease development? I have no any conflict of interest. So as we all know, chronic liver disease have an important health and economic problem in the world. In the United States, there are 150,000 patients with chronic liver diseases, and also 30,000 people with cirrhosis per year. 36,000 people die from chronic liver diseases in every year. 5.9 million have chronic liver disease-related ambulatory care visits, and almost 660,000 patients have liver disease-related hospitalization. Health care are cost more than 1.5 billion in a year in the United States. So this is a very important problem. So we have to measure and diagnose also significant fibrosis in those patients. So what is the reason to detect the fibrosis? Significant fibrosis, which indicates that the patient should receive anti-etiologic therapy. For example, if the patient have hepatitis B infection, then the patient have more than F2 fibrosis, then this patient should have antiviral drugs. Or if the patient has hepatitis C infection, then if the patient also have a F2 fibrosis, then this patient also should have direct antiviral drugs. For example, if the patient had the alcoholic liver disease, then if the patient also have F2 fibrosis, these patients also should have a treatment. So we can enlarge this kind of samples. Another indication to detect the cirrhosis and also to decide long-term antiviral therapy, more often monitoring for complications related to portal hypertension and regular screening for hepatocellular carcinoma. As we all know, again, liver cirrhosis and fibrosis can be reversed by etiologic treatment. If you treat the patients, for example, in hepatitis B patients as an antiviral treatment, then this patient fibrosis can be regretted. Hepatitis C also the same, autoimmune hepatitis also the same. If you use anti-etiological drugs, then the cirrhosis can be reversed. There are many literature about that. So how can we detect the significant fibrosis? Shall we do liver biopsy or non-invasive methods? So liver biopsy is considered as a gold standard for diagnosing liver fibrosis. But recently, these ideas, consensus reports, little bit begin to change because of a stiffness measurement. A biopsy specimen represents at most one division 50,000 of the total liver mass. Sampling error and inter-observer variability may reduce the diagnostic accuracy of liver biopsy. Liver biopsy is an invasive and expensive method. It's hard to patients to receive repeated liver biopsy to monitor the progression of the disease. Also, liver biopsy has a complications. For example, hospitalization rate 1.4 to 3.2%. Mortality rate is 0.008%. Also, there are some contraindications such as higher INR, more than 2.5 times, and also less platelet count, less than 50,000 per deciliter. These are the contraindications for the doing biopsy. So measurement of the stiffness for diagnosing of liver fibrosis can be measured by these devices. One transducer just attach the ultrasound probe, and this transducer produce shear wave from the depths of almost 25 to 65 centimeter, just among the ribs, and this shear wave can be measured by this kind of device. There are two machines, I will explain later. One is FibroScan, the other one Live Touch machines. These reliable transient elastography assessment has been defined as an assessment fulfilling three characteristics. At least we have to read 10 times, and success rate measurement should be more than 60%, and interquartile rate, division median rate, should be less than 30%. If you compare these two devices, FibroScan has several probes: S probe, M probe, and XL probe. So S probe just use 5 megahertz transducer, and the stiffness takes place between 15 to 50 millimeter. M probe uses 3.5 megahertz transducer, and its measurement of liver stiffness takes place between 25 and 65 millimeter. XL probe uses 2.5 megahertz transducer. Measurement of the liver stiffness take place between 35 to 75 millimeter. But Live Touch probe has dynamic wideband probe measuring 1.5 to 5 megahertz. A measurement of liver stiffness take place between 15 to 85 millimeter. Transient elastography measures liver stiffness over volume that is approximately a cylinder of 1 centimeter diameter and 2 centimeter long, which is 100 times bigger than the biopsy specimen, and is thus much more representative of the entire hepatic parenchyma. So what are the indications for performing transient elastography in chronic liver disease? The primary indication for performing transient elastography for the measurement or assessment of the liver fibrosis to guide treatment decisions. Also, it may be helpful in selecting patients for antiviral therapy or anti-etiological therapy, predicting outcome of chronic liver diseases. Transient elastography may differentiate immune tolerance phase and immune clearance phase in patients, E antigen positive patients. Also have a role distinguishing patients who have inactive carriers from those who have ongoing disease activity, cutoff level less than 5 kilopascal. Also, transient elastography may have a role distinguishing patients who have alcoholic liver disease, cholestatic liver disease, and the NASH. Transient elastography may have a role monitoring response to the treatment. But at the same time, there are several confounders for reliable diagnosing of liver stiffness. For example, higher body mass index, higher than 30 kilogram per square meter, or operator experience fewer than 5 examinations, older ages, more than 52, or female gender, systemic hypertension, or type 2 diabetes, or extensive liver necroinflammation, such as acute hepatitis, hepatic congestion, or cholestasis, or ascites, or postprandial measurement. Also, the patient should be at least 2 hours fasting condition. And also ALT elevations is important. 6 to 9 kilopascal is a gray zone in patients with normal ALT, and elevated ALT 1 to 5 times the upper limit of normal were considered in the gray zone of if their stiffness measurement range between 7.5 kilopascal and 12 kilopascal, then those patients should have a liver biopsy. There are some consensus recommendations for liver stiffness measurement. Patients should be in the spine position and right arm in full abduction. Reference site of stiffness measurement is the mid-axillary line in the first intercostal space below the liver dullness upper limit. And at this, the patient should be fasting position condition at least 2 hours prior to the procedure. And the interquartile rate per M should be less than 30%. And also, we have to strongly recommend at least 10 valid shots. There is reasonable evidence indicating that transient elastography can be performed in a reliable way by both physicians and technicians, but the condition in the case of at least 500, more than 500 examination experience. Okay, when we look at the study about the chronic hepatitis B, performance of transient elastography for the detection of significant fibrosis. This means F2 fibrosis. There are several authors, as you see here, Dr. Degos, Marcelin, Cordozo, Vigano, Oliveri, Leishmana, and so on. But if you look at the cutoff value, if you accept the cutoff value as 5.2, sensitivity 89%, but specificity less, 38. If you increase the cutoff value, then in this case, sensitivity will be decreased, but specificity will be increased. So during this accepting of cutoff levels, we should be careful because many diseases, many factors such as steatosis, such as perisinusoidal fibrosis, just influence the cutoff value. So because of that, we have to be careful. Again, in chronic hepatitis B patients, after F4 fibrosis, when you accept the cutoff value, as you see different authors and different cutoff values. For example, you can accept 9 cutoff, but in those patients, sensitivity 100%, specificity 88%. If you accept cutoff 13.1, then in this patient, sensitivity is 75% and the specificity 93%. So this slide shows diagnostic accuracy of FibroScan and comparison to liver fibrosis biomarkers in chronic viral hepatitis. This is the FibroStick study. A diagnostic accuracy of non-invasive test was high for cirrhosis, reaching almost 60%, but poor for significant fibrosis. This is another elegant study from Dr. Zhu, performance of transient elastography assessing fibrosis of single hepatitis B virus infection. This is a systematic review and meta-analysis of the diagnostic test. 14 studies for significant fibrosis from Europe and Asia, almost the patients 2,318, and 18 studies for liver cirrhosis from Europe and Asia, and the patients number 2,996. When you look at the ROC cutoff levels, if you choose 0.80 in European patients, summary sensitivity is 73%. If you accept cutoff levels 0.87 in Asian people, then also summary sensitivity is 73%. However, specificity is a little bit changing. In European patients, 66%. In Asian patients, 82%. About the cirrhosis, in European patients, if you accept the cutoff level 0.90, summary sensitivity is 67%, but in Asian patients, 81%. But specificity, a little bit higher in European patients in this study. Another very elegant study, Dr. Lee from Dr. Lee. This is a systematic review with meta-analysis and diagnostic accuracy of transient elastography for the staging of liver fibrosis in patients with chronic hepatitis B. If you look at the fibrosis stage from F2 to F4, summary sensitivity also, as you see here, will increase. And from 0.80 to 0.86. OROC analysis also for the specificity also increasing from 0.88 to 93. So optimal cutoff value for transient elastography for diagnosing of liver fibrosis in chronic hepatitis B. For F2, cutoff value 7.2 kilopascal, for F3, 9.4 kilopascal, and F4, 12.2 kilopascal. Dr. Xiaolong also reviewed and published these articles. This is also very nice articles. Pool sensitivity 78% for F2 to F4. But for cirrhosis, pool sensitivity is 84%. Specificity, 81% for F2 to F4, but for cirrhosis, 87%. How about the chronic hepatitis C? There are two elegant studies about Dr. Zaigham and Dr. Castera. If you look at the F2 fibrosis, cutoff value for Dr. Zaigham 8.8, Castera 7.1, but severe fibrosis for F3 9.6 and 9.5 respectively, and for cirrhosis for F4 fibrosis, cutoff value 14.6 and 12.5 respectively. Again, this slide shows box plots of liver stiffness values for each fibrosis stage because of the wide range of FibroScan values for F3. The vertical axis is a logarithmic scale and adapted from Dr. Zaigham and Dr. Castera. When you look at this picture, we can differentiate F4 patients from F1, 2, and 3 patients. Also, another Castera literature, Again, we can differentiate F4 fibrosis from the other F1, 2, and 3 fibrosis cases. This is another prospective comparison of transient elastography, fibrotest, APRI, and delivery biopsy for the assessment of fibrosis in chronic hepatitis C. When you compare F0, F1 versus F2 and F4, F2, 3, and 4. Please look at this one, this graphic. FibroScan, blue one, fibrotest, red one, but in combination, FibroScan and fibrotest combination looks like is the best option for the diagnosing of F2 and 3 and 4 fibrosis. If we compare F1 to 2 and versus 3 and 4, in this patient, again, the combination FibroScan and the fibrotest together maybe is the best option, but only FibroScan is the second option, looks like second option. Again, in this study, F4 fibrosis can be easily differentiated from F1, F2, and F3. On the right side, figure C, if you compare F1 to 3 and versus F4, again, FibroScan is the best option, and other option, FibroScan plus fibrotest combination together. But APRI and the fibrotest one by one, I mean alone, is not so sensitive. In hepatitis C patients, it was published that optimal cutoff F2 patients for 7.1, F3 patients 9.5, F4 patients 12.5. This is almost accepted from the other authors. Non-invasive assessment of liver fibrosis by measurement of stiffness in patients chronic hepatitis C, another study. Again, cirrhosis easily can be differentiated from F1, F2, and F3 fibrosis, but it looks like difficult to differentiate F2 and F3 stages. Again, fibrosis stage F0 and F1, 5.5 kilopascal median value, F2 6.6 kilopascal, F3 10.3 kilopascal, F4 30.8 kilopascal. This little bit higher than usual measurements. If you look at the cholestasis cases, the combination primary biliary cholangitis and primary sclerosing cholangitis, it's easy to differentiate F4 fibrosis from the other F1, 2, and 3 fibrosis cases, both histological stage and fibrosis stage. In this slide, we can separately can see primary biliary cholangitis and primary sclerosing cholangitis, and the distribution liver stiffness values according to cholestatic diseases. On the left side, primary biliary cholangitis, right side on the sclerosing cholangitis, and we can differentiate easily again F4 fibrosis from the other F1, F2, and F3 fibrosis. Both the same as primary sclerosing cholangitis also. So another study in non-alcoholic fatty liver disease, if we look at the fibrosis stage F2, there are several reports you see on the left side, and there are huge differences between the cutoff value. For example, 6.2 and the 11. When we look at the 11, sensitivity 61%, but specificity 100%. If we look at 6.2, sensitivity is higher than 90%, but specificity cannot be available. If you look at the F3 fibrosis, again, there are several differences, huge differences between the cutoff values. This means it's difficult to differentiate F2 or F3 each other. Again, if you accept the F4 fibrosis, then cutoff value 9.5 to 20. The performance of control attenuation parameter compared with liver biopsy for the detection of various steatosis grades, you see there are huge differences between the researchers, 214 to 318. Of course, this kind of variability depends on the etiological diseases. For example, hepatitis B alone or hepatitis B with steatosis. Hepatitis C alone or hepatitis C plus steatosis, or alcoholic disease together with diabetes or together with obesity or something. It depends on the conditions. Of course, because of that, these kind of CAP are huge difference, shows huge differences. Again, analysis of transient elastographic cutoff for the diagnosis of NAFLD in adult patients, histological evaluation by Metavir and the Brandt score. If you see F2, optimal cutoff value changing from 6.6, 7.4, 6.8, 7, and 8.3. If you look at the F3 fibrosis, optimal cutoff again changing 9.8, 10.2, 10.4, 8.7, and 4.7. But if you look at the F4, optimal cutoff value 17.5 and the 10.3, 19.6. As you see here, there are huge differences between F2, 3, 4 due to the different pathologies in the liver. So individual patient data meta-analysis of control attenuation parameter technology for assessing steatosis. You see here HCV, HBV blue color and the NAFLD and NASH green color. The results of the linear mixed model to determine the influence of etiology and other covariates on CAP values. Body mass index, diabetes, and etiology are found to have significant and relevant influence of CAP. Here is again alcoholic liver disease and transient elastography. Liver stiffness measurement and fibrosis stage, according to Brandt et al., was significantly different between the patients according to the fibrosis stage. Here is another example, metabolic syndrome. Distribution of liver stiffness values in 429 healthy subjects without any overt causes of liver disease and normal liver enzymes, according to the presence or absence of the metabolic syndrome. As you see here, no metabolic syndrome, normal ALT levels, but here there is a metabolic syndrome, and there is a differences between the two conditions about the fibrosis. Again, assessment of asymptomatic liver fibrosis in alcoholic patients using FibroScan, prospective comparison with 7 non-invasive laboratory tests. You see here in alcoholic hepatitis patients, cutoff value higher than viral diseases. We accept already optimal cutoff value, almost 17%. But here, as you see here, 45, cutoff value 45. In activity, also higher than the liver infections diseases. A3 already accepted 58. Also steatosis higher than the normal hepatitis B and hepatitis C cases. So in these slides, again, liver fibrosis in alcoholic patients using a FibroScan, prospective comparison with 7 non-invasive laboratory tests, box plots of liver stiffness as a function of metabolic fibrosis, inflammatory activity, steatosis, and penile-sinusoidal fibrosis. You see here, if you see the fibrosis, there's a good correlation between the F4, F3, and F2, and F1, F0. However, how about metavir activity not regularly correlated? Also, the other, steatosis and the perisinusoidal fibrosis are not regularly correlated each other. Areas under the ROC curves and the 95% confident intervals for FibroScan and comparison to 7 non-invasive laboratory tests. This is reported by Nguyen and et al. When you see the FibroScan results, F1, 2, 3, and 4, FibroScan is the best options for the diagnosis of fibrosis. But oppositely, EPRI less sensitive for the diagnosing F1, F2, F3, and F4. So there are several articles about correlation, comparison, FibroTouch, and FibroScan for the liver pathological stages. 75 cooperative study, and among the 75, almost 46 was performed over biopsy, and from FibroTouch and FibroScan were not significantly different. The two technologies are correlated each other based on the histopathology. Another comparative study, comparison of FibroTouch and FibroScan for staging fibrosis in chronic liver disease. As you see here, almost 4 patients failed in FibroScan, but no any patient failed for FibroTouch. Body mass index less than 25 kilo. If the body mass index less than 25, then in those group, 2 patients failed for the measurement, and also 2 patients failed in patients with higher body mass index higher than 25. Another point, important point, measurement duration, short in the FibroTouch compared to FibroScan. And also, when you look at the picture A, FibroScan and FibroTouch almost regularly compatible each other, and the much more sensitive than the other EPRI and FIP4 or the others. If you look at the fibrosis, severe fibrosis, again, FibroTouch and FibroScan, it's much more sensitive techniques compared to EPRI and FIP4. And also for cirrhosis, for fibrosis, FibroTouch and FibroScan compatible each other and much more sensitive than the EPRI and the FIP4. So clinical significance of liver stiffness cutoff in chronic liver disease. This slide was shown by Dr. Abbas. And if you see these slides, absent or mild fibrosis, cutoff level 2.5 to 7. If there is a significant fibrosis, cutoff levels 7 to 9.5. If severe fibrosis, 9.5 to 12.5. But if cirrhosis, then cutoff value higher than 12.5 to almost till 75 kilopascal. As you see here, there are several conditions such as hepatitis C, A, B, HCV plus HIV co-infection, C, hepatitis C recurrence after liver transplantation, and the D, hepatitis B, and E, chronic cholestatic diseases. If you look at the colors, almost F2 similar all the conditions, but F2 and F3 little bit changing between among these conditions, but after F3 almost the same in all the conditions. That means F4 liver cirrhosis can be differentiated from almost all chronic liver disease from F3, F2, and F1. This is another study. You can see significant fibrosis and severe fibrosis cutoff levels from different authors. Here is also for liver cirrhosis, different diseases, different cutoffs. But in the cirrhotic patients, cutoff levels very near each other. That means easily can be differentiated from the other fibrosis condition. So we have performed one study comparing two transient elastography techniques, FibroScan and leaf touch. We used almost approved 254 patients. This is unpublished data yet, but on the process now. If you look at the failed cases, almost 6 cases failed for measurement of transient elastography in FibroScan, but no any case failed for measurement of transient elastography for FibroTouch. If you look at the leaf touch and the echo scanner, comparing two techniques, there's a good correlation between the two techniques. Also, there's a good correlations, leaf touch and FibroScan stiffness results between APRI, FIB4, and the NAFLD fibrosis score, as you see in this slide. CAP and the ultrasound attenuation parameter scores were significantly correlated with body mass index and correlation coefficient of ultrasound attenuation parameters was higher than CAP. So 31 patients had liver biopsy. Diagnostic performance of detecting advanced fibrosis, METAVIR F2, higher than F2. You see here FibroScan and the leaf touch almost very reliable. Also, NAFLD fibrosis score reliable, but APRI and the FIB4 is not reliable for the diagnosing of F2. Again, diagnostic performance according to cutoff value. If we accept 7.25 kilopascal with the FibroScan, sensitivity 85.7, specificity 66.7%. But if we accept 8.5 kilopascal, then sensitivity is 78.5% and 66.7%. But with the leaf touch, if we accept 7.85 kilopascal, then sensitivity 92.9, specificity 60%. If we accept 11 kilopascal for leaf touch, sensitivity increasing 100%, but specificity 66.7%. Stroke analysis of fibrosis, leaf touch, APRI, FIG4, and the NAFL fibrosis score according to significant or advanced fibrosis. You see here, APRI in this both conditions less sensitive, but FibroScan and FibroTouch, leaf touch, much more sensitive than the others. Okay, the same. Ms. Yang-Ling, ladies and gentlemen, as a conclusion, leaf touch and FibroScan measurements are recommended as the initial investigation for determination of hepatic fibrosis. Both F2, F4, and F4 in individual with chronic liver disease not undergoing liver biopsy. The patients who have normal ALT with stiffness measurement of 6 to 9 kilopascal and who have elevated ALT more than 1 to 5 times more than normal, upper limit of normal, with stiffness measurement 7.5 kilopascal and 12 kilopascal are considered in gray zone. Those patients may undergo liver biopsy. The diagnostic accuracy of non-invasive tests was high for cirrhosis, but poor for significant fibrosis and also severe fibrosis. Leaf touch and FibroScan techniques for staging fibrosis are more sensitive than APRI and the FIB4. There is a good correlation between leaf touch and the FibroScan measurements for the diagnosing liver fibrosis in patients with chronic liver diseases. Measurement duration of FibroTouch is shorter than FibroScan, and more patients failed for measurement of liver stiffness in FibroScan technique compared to FibroTouch. Thank you very much for your patience.
Thank you very much, Dr. Necati. So first question is about the Necati, Professor Necati, and when audience ask the question about any study related inflammation influence for the diagnosis for liver fibrosis, or what is your suggestion for this topic?
In acute liver disease, such as acute hepatitis B or acute hepatitis C, generally, as we know, ALT levels higher than 1,000. So in those patients, of course, liver stiffness measurement cannot reliably. So we have to be patient, be careful to evaluate those kind of results. We have to wait and we have to follow the patients and then again repeat, and then finally we can decide the real stiffness measurement.
Thank you very much. I also agree with your opinion, because we need to wait and need to monitor during the inflammation activity stage. Yeah, thank you very much.
Right.
And also, I have one question for Professor Abbas, and we also just now you also talk about the cut value to evaluate the portal hypertension, especially for the various bleeding risk in different stage, in different study. And in this study, I pay attention to that the cutoff value varies very greatly. And so can you give us some opinion about why there are so large variation for this this cutoff value in different study? This is due to the etiology or inflammation or some other factors influence this result?
So there are some variations, but variations are not very wide variations. These are the small variations. But these are the variations that tell us how the varices are going to behave with the increasing stiffness. Like I mentioned, that if the stiffness is more than 25, then this may be the area that we should screen our patients for varices, because if another study showed that this was the expanded Babino 6 criteria that are showing that if the stiffness is less than 25, then there is a less chance that you will be having the large varices. So, but the other study showed that this chances of having large varices is more than 27.5. So these are not the big differences, 27 or 25. So these are the small differences. So if we remember the round number, which is 25 kilopascal, then if the platelets counts are less than 110,000 or less than 100,000, then we should offer screening for varices in these patients. Again, the chances of bleeding from the varices, this becomes more when you have the higher kilopascal values. Like if the values are 50 kilopascal, then these are the retrospective data, because one study showing that chance, because they had taken history from the patients and they followed the patients with kilopascal, and they one study came across that if the value is more than 60 kilopascal, another study and more than 50 kilopascal. So so it means that if we remember that, okay, if you are 20 more than 25 kilopascal, you should screen your patients definitely. And if you are more than 50 kilopascal, there is a very high risk of having the variety of bleeding. So we should not forget. So these figures are easy to remember, 25 and 50. So 50 is equal so to 100. So 25, 50, I think cutoffs for ordinary purposes, we should keep this in our mind.
Thank you very much. I also agree with this one, because in our study, we also found that 25 is the very good cutoff for the big or the large size of esophageal.
So I can see one from the chat, that according to the expanded Babino 6 criteria for screening of varices, the new expanded criteria, liver stiffness meant less than 25, or can help in avoiding 40% of the endoscopies and miss less than 5% of the variceal needing treatment. Can you share your experience about the advantages of transient elastography? Can you avoid liver biopsy? I think there is no role of liver biopsy in just showing, because this is an invasive procedure. In the cases of cirrhosis of liver, when you have the advanced cirrhosis, because 40 or 45 kilopascal or 50 kilopascal means these patients are having the advanced sort of clinically advanced liver disease, and most of the time you already have the diagnosis. There is no need for having liver biopsy in most of the cases, just to document that this is patient is having very high level of fibrosis. Because that's why there are non-invasive management tools that help us, like transient elastography, FIB4, and FLD fibrosis score, and other scores that are available. You can predict how these patients are going to behave in future. So I would not say that liver biopsy is mandatory in these cases.
So recently, I also read some paper. They also measure the spleen stiffness, and it's also helpful us to monitor the portal hypertension or liver fibrosis. So how about you? Can you give us some comment? We also haven't done the spleen stiffness measurement because there are too many patients who measure the liver stiffness, so we cannot operate so many patients. Yeah.
Yeah, liver stiffness also very important. Another device. I think also trustable results can be obtained from several literatures.
Yeah, I think so. That's is also a new method maybe to increase the value for to evaluate the esophageal varices.
That's right.
Thank you.
So this device is a little bit expensive, the same as the other transient elastography machines, and it's sometimes difficult to buy those both machines. I mean, liver stiffness machine and also spleen stiffness machines. So in my department, already only FibroScan and Live Touch. We have two different machines, but we don't have a spleen stiffness machine now.
Thank you. I have one question for Professor Abbas. I think for NAFLD, it's very difficult to measure the liver stiffness because this patient always have liver steatosis, and this maybe can reduce the cutoff value of the liver stiffness of the liver. So can you give some comment to how to increase to measure the liver stiffness to evaluate the esophageal varices in this NAFLD patient?
Actually, I have the experience of using both FibroScan and FibroTouch, and we do not have the Excel probe with us. So with FibroTouch, the beauty is that even for the obese patients, we can have a good measurement of estimate of liver elasticity even in obese patients also. So if we see obese patients, we are using FibroTouch scan to measure the elasticity.
Thank you.